Now I have the pleasure of and the honor of introducing Dr. Stephen Schwaitzberg. Dr. Steve Schwaitzberg is the Chief of Surgery of the Cambridge Health Alliance and Professor of Surgery at Harvard Medical School. And if you read the bio, you can tell the long list of accomplishments he's had, hundreds of publications, videos, past, present, and SAGES. But I want to tell you that a little known fact, or maybe a lot you know, he also was a former military person. He was a major in the Army, both in active duty and reserves. And with the help of Dr. Schwaitzberg and Colonel Rob Lim, who's deployed, he really has been a proponent of military, especially at SAGES, and helping our society, the military working group, and our symposium really grow. And we owe him a debt of gratitude for all of his help. So it's my honor to introduce Dr. Schwaitzberg, who is going to talk about transition to civilian practice, and I can't think of a better person who's done it more successfully.
Thank you so much.
Thank you.
It's an honor and a pleasure to be here. I said this publicly. I'm embarrassed to state that it took a phone call from Rob Lims asking me who's in charge of the military working group when I turned and said, we don't have a military working group, which is a real embarrassment for a former reservist and somebody who had been deployed in the theater of operations. So kudos, really kudos to Rob. I just ran the politics for him, but maybe that has a value as well. So number one, thank you for your service. And I know we say this sometimes, and sometimes it comes off as if it's just the trite phrase, but I've been there, and so you know that this comes from the bottom of my heart. All right, let's go the right direction. So, you know, surgery in the civilian world is not, you know, it's not like the good old days. In the good old days, the civilian practice was sort of like a war zone of its own. I trained in the Ben Taub Hospital, and we had many, many military trainees because there was more trauma and murder and violence and bleeding and mayhem than there was in some of the peacetime military operations. But it's not a free-for-all anymore. I mean, it was literally a free-for-all back then. And residents ran the hospital, and attendings were more like little countries, but it's really changed, and through my lifetime, the practice of surgery has changed dramatically. So what's going on here? Let's take a little closer look at what some of the options are as you transition to practice. Number one, if you didn't do a fellowship, recognize that 80% of the people that trained in the civilian world, that went into practice in the civilian world, that are graduating today, and maybe your contemporaries, will do a fellowship, a clinical fellowship. Number two, the issue around competency assessment, starting with FLS, starting with FES, is starting to become a big deal. If you have not applied for civilian privileges in a hospital lately, and I hadn't applied for privileges in years, and I'm moving to the University of Buffalo to be the professor and chair there, and I had to fill out application forms for medical staff privileges. It took a long time. And I had to show evidence of child abuse training and infection control training. And then there was something that I looked at and asked me, was I competent to do lap chole? And I felt like handing them my paper with like 1,000 cases on it. But you know, it's a real issue, and bringing evidence of competency to your practice, because when I got to Tufts initially, you know, 28 years ago, I just started checking boxes. I want to do Whipples, and I'm going to do this, I'm going to do that. You're going to have to provide evidence of training and competency, and so you should be collecting cases and collecting your case numbers, because people are going to ask you as you transition to civilian practice. We're going to talk a little bit about employment models and economics, because the economics and the employment models are completely different than from what you're used to. We'll talk about the payment models, because it's one thing to be employed, it's another thing to understand how you get paid. You may have had access to great technology, you may have access to no technology, but you need to know that it's not the same everywhere you go. And the last thing is, and I'm happy to take an email from anybody anytime if you have questions about how to get a job and what to interview for, and we'll cover some of that. So here's the problem. If you haven't done a fellowship, you're competing against an ever-increasing group of people that have specialized credentials. And one of the really great things is the opportunity that it's afforded to many of you to go out and do a civilian fellowship. That's where I met Rob, that's where I met Henry, that's where I met a number of people who have taken advantage of that. And if you haven't done that, then I encourage you to take advantage of that. And I've met people who have been in the military for 10 years before they went out and did their fellowship, and it's really, congratulations. I could never do that. Once I was locked into practice and 10 years into practice, I would take a huge pay cut. You're just doing your job, and that's like the amazing advantage that you have, and if you don't capitalize on it, then in many ways, shame on you. Let's see. So what are the issues? When you go to get a job, you've been traveling around and maybe you've been deployed, but when you leave the military, the rules change a little bit. For me, I advise people, number one, what does your spouse think about all of this? Where do they want to go? I have a number of trainees. I get phone calls all the time. They trained with me in general surgery. They go off and do a fellowship, and they say, listen, I got this job in New Jersey, and I have this job in Texas. What do you think I should do? And I always ask the same question. Where does your wife want to go? Or if it's a woman, where does your husband want to go? And if it's a partner, where does your partner want to go? So that's not a small issue. And the reason why it's not a small issue is you have to, if you're going to settle down and start the next phase of your life, for many people, it's a time where they start their families. Some people already have families. Some people are getting out of the military after 20 years. Their life is established. They may already be empty nesters. But for some people, maybe you've had a scholarship, or you signed up, or you did your time, you've served your country, and if everybody served, then nobody would have to serve for a long time unless they wanted to. And now you have to start thinking about these things. You have to design your life. And I can tell you, as a very busy surgeon, with my wife being a gynecologist, if we didn't live near her family, I don't know how we would have made it when the dirtiest word in our house would come up, and that was snow day. So you can imagine what it's like. You got to design, you got to plan for this. Before, you may not have needed to plan for this. But as you go into the next phases of your life, it's a really difficult choice. Does 3 lap choles beat 12 patients in GYN clinic? Now, you got to have rules for this kind of thing and understand what your problems are. Number 2 is location. Where do you want to live? Because wherever you go next, there's a good chance that you're going to stay there for a long time. I trained in Texas, thought I was going to do this little fellowship in pediatric trauma and critical care, thought I was going to go back to Texas in a year, and it's 28 years later and I haven't made it back yet, other than to visit. So where you go really matters. So don't say, well, I'm going to go, and maybe if I don't like it, I'm going to move. There's a good chance you're going to go, and hopefully you will bloom where you're planted. The employment models really matter now. The days of going into private practice are just so rare and so infrequent. There's a good chance you're going to be employed by a hospital, health system, or a large group. And that really raises the issue of, is this a group that is there to do surgery and there to take care of patients and essentially, maximize your financial potential, or are you interested in academics? The number of people that go into academics after not starting in academics is as small as a thimble. And so either you make that decision now, and maybe you didn't have a chance, but you still have a chance when you enter into practice if you make a concerted effort. And this is a really fascinating topic because I had a chance to speak at the Women in Surgery Conference over the last several years. I didn't do it this year because I was on vacation. But one of the interesting things about a lot of young women who are in civilian practice and they go immediately and start their families, that when their kids are a little bit older and they think they're ready to do some other things, they're like 40. And there's this entire amazing transition issue for people who are 40 who want to enter academics. My wife was in private practice for 10 years and started her academic career mostly because of being in private practice, because it worked for her life. She headed back to the medical center where she's trained, and you can really do it. She's about to become the Associate Dean for Medical Student Curriculum at the University of Buffalo. So you don't have to say, because I haven't done academics for a number of years as I was fulfilling my military commitment. Now, not everybody's as lucky as Matt. Matt is a true academician, some other people here. But if you haven't had the chance because of the nature of your deployments, don't sell yourself short if that was your dream. Do you need to do more training? Are there operations do you wish to do? Do you want to do robotics? Do you want to do minimally invasive, endoscopic therapies and this and that? Then you want to take the opportunity to either figure out how you're going to do it before you start practice, or figure out how you're going to do it in practice, or take the time to identify those areas of opportunities now. And for some of you, you're going to go into the reserves because you have a commitment. And you have to, when you think about your job, you want to be able to bring that up. Yes, there's laws that protect your job and all that, but you have to think about the employment model. Now, I was a reservist. And I was at an academic center, and there was a job waiting for me when I got back, and I am very grateful to my former chair, who was really outstanding during my time away. But I've met a lot of private practice guys whose practices closed because they were it. And so if you have a reserve commitment, you need to ponder what that's going to mean to you, and are you going to go to a place that's going to be, there are some choices that are better than others as you contemplate that. So, now the question is, are you a general surgeon? Are you a general surgeon, or are you a specialist surgeon? Your training in the military prepares you to think about being a general surgeon, because particularly in the trauma world, you've got to operate on every part of the body. You are awesome general surgeons based on your experience. Are you a general surgeon? Do you want to be a general surgeon? And one of the interesting things, if you listened to Frank Lewis earlier today, is, are the ACS surgeons the new general surgeons? And I would contend they're one of the groups of new general surgeons, and the other group are the general MIS surgeons who operate everywhere in the body as well. But the difference is the MIS surgeons are in practice for the most part. I have patients that I've taken care of for 28 years that I'm going to say goodbye to. The ACS surgeons in this new model is more like, I come, I conquer, I leave, I'll be back in a day or two. You have to ponder what you want to be. As I said before, you're unlikely to go into private practice, but as you look at these salary models, you got to understand what it means to you, because you get a paycheck. I was fascinated by the data you showed with no surgeries. If you were in private practice, those would be just not good days. Not good days, unless you were on salary. Now, you're in a salaried model. It's awesome. But you're not going to always be in a salaried model unless you're very lucky. And so you have to look at what's happening in America. People are becoming employed, productivity rules, and for some people, there are some salary models. I'm on salary because I'm the chief. They don't care how much I operate. I do a lot of surgery, but they don't measure it. But if you go to a group, you're going to get a guarantee for somewhere between 18 months and 2 years. If they don't offer you 2 years, that's not standard. So I know some people who get 18 months. I know some people get a year. You often can do better. You really are looking for at least 2 years of guarantee, because it takes time to build a practice. Then you're going to reach a stage that you're going to perhaps eat what you kill. And that becomes a very competitive environment. You start competing with everybody around you, because even every little gallbladder matters, because it's food on your table. Do you want to be in that environment? For some people, they can make a tremendous amount of money. For other people, they don't want to practice that way. And they work on another system called RVUs, where you work on a published metric. It's $50 an RVU, $52 an RVU, depending on what specialty that you're in. And the reason why that's important, whether it's cash or published metric, is because if you have a Medicaid patient and you're going to do a lap chole, guess what? It's $300. If you do a Blue Cross patient, it's $900. And many people do not want to get into that incentive divide based on the payment reimbursements. RVU models are much better because it doesn't force you to deal with the ethical problems of dealing with financial hot potatoes. And you have to understand that when you walk into the job, because it's not the way it works for you now. When you go look at a job, is there a vacuum and they can't wait for you to arrive? Or are you going to have to bring your crowbar with you and fight your way into the practice? Now, some people do that because they know they can compete. B, they know they need to live in this city or that town because that's where their wife wants to go, or their husband or their spouse or their partner. And you have to know, am I going to a vacuum or am I going to a crowbar? Do they need me or do I need them? And you just have to know that walking in, because it makes a big difference of how the first couple of years of your life is going to be. I've seen people walk into a completely crowded medical environment and just kick it and kick ass on everybody. It can be done. You just have to be up for it. So what's happening now on the outside? There was payment reform. I live in Massachusetts. That was the home of payment reform. We're developing an accountable care organization, and you need to understand these things as you look at different jobs. How do people get money? And what are the implications? The healthcare reform is a question of evolution versus revolution. The one on the left is Karl Marx, and this one is Darwin. And evolution is a gradual, peaceful process of socioeconomic change and development. Here we are, we're evolving into man. You've seen versions of this slide that we may be devolving into other forms of life. But this is really what's happening. The contrary view is revolution, a complete and sudden complete and sudden change, and this is what happened when Obamacare came along. This is a radical shift in the economic payment mechanisms in our country, and you need to understand it as you transition to civilian care. This has really changed the world, but unfortunately it's not healthcare reform, it's insurance reform. And you need to understand that many aspects of healthcare have not changed, and the changing of one item is a problem. So if you really want to understand it, you follow the money, and this is really about moving the money around, and this is a big problem for all of us. And that's why it's very important where you get a job. Fee-for-service is easy to understand. You give them a gallbladder, they give you $1. It's pretty easy. The incentives in this kind of world are you work hard, do lots of surgery, stay late, go fast, be efficient, take call, and those dollars will add up and people can do really very well financially. The interesting problem is it creates perverse incentives, and this is why you need to understand this when you want to understand where you want to work. If I do a consult for a hernia, I get about $125 from a good payer. If I fix your hernia, I get about $800 or $900. Now you tell me, where's the incentive? Now, here's the even bigger problem. It's not just us that have a problem with this. If you're the hospital, look at the pile of cash they got. You got a little bit of money, but they made a ton of money. So hospitals are currently incentivized for you to do all kinds of things to people, and we're the interventionalists. We are the interventionalists, and we get paid well to do things. The hospitals get paid better in a fee-for-service system. Now, Medicare tried to fight this. And they understood that as they declined reimbursements, surgeons like you would want to do more. So they enacted the SGR, which essentially meant you can't make it up on volume, and started creating these deficits that were finally repealed this week, where if the SGR went through, you would take a 40% cut in reimbursement if they finally killed it, and we would have unsustainable debt. However, the SGR repeal is not completely funded, so stay tuned for more. So healthcare reform, I don't think so. It's really insurance form. And it has created headaches for many of us in an era of declining reimbursements. Now, what is all this about? It's a fixed pot of money. They're just moving it around. So you got to learn where the incentives are in the new game. And they want to take dollars out. If you notice, there's fewer and fewer dollars. And they're getting smaller as they move around. So real healthcare reform is going to require more than just finance reform. There's a lot to do. And for many of you who had your educations financed through the military, God bless you, because many people have hundreds of thousands of dollars of debt that you won't have to worry about, and you can start your life and buy a house. If you came out with $300,000 in debt and then you have to get a job, you're just starting in the hole. And that's one of the great rewards that you get for having served your country. I went to Baylor. It was only $400 a year, so it wasn't a big deal. So it's a series of dominoes that we have to think about. Now, how to think about where this healthcare reform leaves all of us. If you think about Obamacare, think Medicaid. Don't think Blue Cross, think Medicaid. And you have to figure out, are you going to take a job in an environment that has figured out how to deal in a Medicaid environment? Because that's where all these types of coverages will go. Let's go on. So let's look at the payment models. Fee-for-service model is dying because it's very expensive. We're incentivized to do procedures, and it creates perverse incentives, in many ways harmful outcomes. But as we think about the death of the private practice surgeon, they're going into group plans because of things like meaningful use. Do you have meaningful use in the military? Do you have to meet meaningful use standards? Oh my God, you got to use the EMR, and you got to send a letter to the patient, and you have to click their Medicaid. I mean, we just start clicking, and I just click everything. And I figured that I've clicked enough that it's been meaningful, and I've never been tagged by our IT department. There are preferred contracting rates. If you want to go into private practice, you have no hope of getting a contracting rate that is going to compete with the group practices that have more leverage in their area. Nobody wants to take call. If you're a solo guy, who's going to cover you? The good news is call used to be kind of for free. Hospitals are starting to pony up because nobody wants to take call. So I guess that's a plus. And how many hospitals do you want to work in? If they don't have the same EMR, it's a nightmare for people, an absolute nightmare. So here's your question. In a fee-for-service, are you a revenue generator or a cost center? In fee-for-service, you're a revenue generator. In an accountable care organization where they deliver you a pot of money, that surgeon who might have done 1,000 cases is now an expense line. And you need to understand what system, in what state you're going to. So if you're going to do a bypass, a band, or a sleeve, are you a revenue generator or are you an expense line? Cost is going to matter more than ever in the future moving forward. It's been a big topic this year. We'll move forward in the sake of time. All right. So what will your priorities be? That's an interesting question. Do you want to be the safest surgeon? Well, we all say we want to be the safest surgeon. Do you want to be the most cost-effective surgeon? Well, we haven't been incentivized to be the most cost-effective surgeons. But I'm going to tell you, within your practice lifetime, your paycheck will have some impact on how much money you spend in the act of providing care. You should plan on it. You should learn what costs what. You should think about the cost-effectiveness of the operations you do, particularly when they're commodity procedures, because it may impact your paycheck, even if the outcomes are the same. As we reorganize, here's the accountable care organization. Here's your pot of money. So for the last 10 or 15 years, we've made the insurance companies the bad guys. And they're smarter than we are because we're busy taking care of patients, and they have all day to think about how to improve their PR. So Blue Cross comes along to our system and goes, here's your pot of money. Have a nice day. If the patient can't have their robotic toenail excision, it's not their fault, it's your fault because you won't pay for it anymore. Split it up any way you want. Now, that's a problem. Because if you want to see a food fight in action, talk about $1 coming into the system in a room full of people like internists, primary care docs, psychiatrists, radiologists, and have a fight for have a great time fighting for your little piece of that dollar bill. But this is why, although I debated that healthcare quality is not physician-driven, I actually believe the opposite. We have to be at the table, because if surgeons are not at the table, then you, my friends, are on the menu. And so as you prepare to enter practice, you need to think about being a leader in your organization, understanding reimbursement, understanding the cost implications, and advocating for yourself, your practice, your specialty, for your fair share of the pot. Otherwise, you will have terms dictated to you. The payers are no longer the bad guys. So systems that are going to be interesting to you will be systems with large primary care base with lots of aggregated lives. I have an aggravated life. Aggregated lives, so that you can be in a system that has dollars coming into it. We have 40% of our patients in a risk pool now, which is pretty huge. So here's the ACO. The PCP is in the center. This has been the apotheosis of primary care. We as a specialty could use a lot of PR with the public directly. They're in the center, and they have all these services, and it's going to make a big difference whether the surgeon is in the ACO or out of the ACO. If we are outside of the ACO and we can charge the ACO for service, that's kind of like fee-for-service. If we're in the ACO, we're an expense line, and we need to function as an expense line. So in the ACO, we have to participate, shared risk savings, fight for funds flow. We move out, and in many systems, the specialists are outside of the ACO, we can contract. You need to know whether, as a surgeon, you're in or out of the ACO, and you need to know these things before you accept the job. What about access to technology? A lot of this will depend on where you work. You will have a whole different layer of access to technology. Some hospitals are deep in the medical arms race and they have every toy imaginable. Other systems are fighting for every nickel that they can hang on to, and you're going to need data. You know, where does notes fit in? Where does, it's still looking for its place. Where does robotics come in? Will notes be revolutionary for the rectal stuff and the poem stuff? What payers don't want are more layers of diagnosis and therapy. We'll move on. All right. Lastly, how do you want to build your practice? If you want to build your practice around smaller incisions, you know, no incisions, and that's how you want to market your practice, the question is, will cosmesis and these kinds of things that made the single port a rampage a few years ago really be the outcomes that count in healthcare? I don't think so in the long run, if you ask me. I think your clinical quality outcomes, quality of life, patient service, the 3 A's will still matter more than anything else as you transition to practice. Here's an example of laparoscopic parathyroidectomies that I were doing. They are completely scar-free. It's the most beautiful operation you can possibly imagine. However, and that's compared to, you know, that's the comparison. However, that when we studied it, it turns out cosmesis is a lot less important to patients than you might realize. And when we asked patients, would you pay extra for a scar-free parathyroidectomy or a thyroidectomy? The answer was no, not a dime. So think about what you're going to build your practice on. So finally, what about your future? You should understand how your compensation is determined. Do you have to buy into partnership? What are your benefits? What is the impact of productivity? If you start in a practice and they give you a salary, sounds pretty good, but what if you kick it? Do you get any of that money? I know plenty of practices where people go, I did 500 cases, I made $180,000. Oh my God, you did 500 cases, you should be paid like $380,000. Because it's the first 2 years, guaranteed salary, no downside, but no upside either. So understand the implications of your productivity as you join. Understand how your organization makes money. If you don't understand that, don't take the job until you do. Understand where the sticks and carrots are. Understand what the plan to partnership is if it's a group practice. And understand whether it's a real academic facility where you can do research if that's your goal, or whether it's just window dressing. So finally, I'm a pilot. If you are transitioning, it's like making a landing. You have to go through your checklist. And the checklist for choosing your practice and transitioning your practice has a lot of items on it. But like anything else, if you don't check your checklist, you are possibly going to make a fatal landing, at least in the figurative sense. So I encourage you to think about all these issues as you transition. Thank you very much. Is that what you're hoping for?